Hello and welcome to this session of the Center for Podiatric Education. In this session, I'd like to speak about a subject that has some renewed interest in our profession, and that is the subject of juvenile hallux valgus deformity and whether or not one should intervene surgically prior to completion of growth, and if so, what procedures would be deemed appropriate. We've seen an increased interest in this subject with the resurgence of the pediatric affiliate of the American Podiatric Medical Association. It's interesting that, as an aside, there are children's characters in children's books that have characters such as Bunyan Burt. We have the Bunyan brothers. We have Mr. Bunyan. And for those of you that are hungry, we have Funyuns, which have, of course, nothing to do with bunions. We do know that parents frequently will bring their children to our offices, and they do have complaints and concerns of a progressive deformity, of painful deformities. And so we do see pediatric patients that indeed have painful bunions. The overall consideration that I have, and I will admit to being a bit more aggressive earlier in my career in evaluating and treating juvenile bunions than I am now, is the very high reoccurrence rate, which has been reported at greater than 60%. And the reason I believe is that, number one, we are somewhat limited in the procedures we can perform in the presence of open physeal plates, particularly at the proximal metaphyseal level. But more importantly is the fact that while we know that many bunions are inherited, what is really inherited is a foot type. And we know that bunions are oftentimes a sign, if you will, or a symptom of a more global process. So, for example, bunions may be present associated with a pronation deformity, and this may be calcaneal valgus of infancy. It may be some compensated deformity, perhaps a compensated forefoot varus or flexible forefoot valgus. But the point is that the bunion is there because of a generalized malfunction of the foot, and so treatment of the bunion in order to obtain a more long-lasting result is going to have to involve stepping back and looking at the foot globally. One of the more common etiologies for bunions in the juvenile patient is that of a metatarsus adductus. And here again, there are multiple issues involved here. My experience has been that the patient that has a bunion with metatarsus adductus typically has a high hallux valgus angle, has a high proximal articular set angle, and the question is, unless you're going to correct the entire deformity, where are you going to put that hallux following surgery? We see bunions due to congenital joint laxity, generalized ligamentous laxity, Ehlers-Danlos, diseases perhaps related to osteogenesis imperfecta. But we see these deformities frequently associated with some degree of ligamentous laxity. There may be instability or true anatomical deformity at the metatarsal cuneiform joint. So that we want to remember that the patient that has a juvenile bunion, whether symptomatic or not, is really coming to us with a manifestation of a more global process. And here, a child with metatarsus adductus demonstrating rather typical early deformities with early hammer toes, a hallux valgus deformity, a bunion deformity, and overall an adduction deformity of that foot. Looking at studies that have been done, we know that there is a large hereditary component when children are brought to us with a bunion and hallux valgus. 90% of these children have a positive family history with an overwhelming female predominance, and this tends to be inherited as an autosomal dominant gene with incomplete penetrance, so that women who present with bunions tend to have female children with bunions. And we do, in fact, see these deformities early on prior to the closure of growth plates or in adolescence. This is not at all uncommon. Now, we have two prevailing schools of thought with regard to bunions. We have those that are the classic Morton type people that believe in the philosophy of Paul Lapidus. And this has direct impact in our procedure selection. So this is more than just a philosophical argument. If you are a person who believes in the philosophy expressed by Paul Lapidus, then you believe that the primary deformity lies at the metatarsal cuneiform joint, as did James Ganley. So that when we do procedures that do not correct the deformity at the level at which it lies, meaning either a Lapidus type procedure or an open up osteotomy of the cuneiform, if we don't do that, then it is understandable that we would see a high reoccurrence rate because we're really not actually correcting the deformity. So this is Paul Lapidus' concept based on Morton's work, in which we have primary instability of the first ray, and this is associated not only with bunion deformity, but medial column instability, inability of the medial column to support the foot, and in fact a pronation deformity in no small part associated with insufficiency of the first ray. And there is no question that when we look at patients that do in fact have a juvenile flat foot deformity, that first ray hypermobility and insufficiency or some insufficiency along the medial column is going to be required in order to give us a foot that looks such as this. If, on the other hand, you are a follower of classic root, weed, Orion, Scarlato philosophies, then you believe that the hypermobility or instability of the first ray is generally secondary to instability of the subtalar joint. And you believe that when the foot is in a pronated position, that the foot becomes hypermobile, that the most distal segments become the most hypermobile, that you have instability of the cuboid due to hindfoot pronation, instability or insufficiency, if you will, of the peroneus longus, and secondary hypermobility of the first ray. So depending on whose philosophical position you wish to accept, you may believe that the pronation deformity is secondary to insufficiency of the first ray, or you may believe that insufficiency of the first ray is secondary to instability of the hindfoot. And this has most definite clinical implications to you, because if you believe that that bunion and flat foot are secondary to first ray hypermobility, then you can argue strenuously to postpone any surgical intervention until such a time that the growth plates are closed and you could go in and stabilize that foot with a Lapidus type procedure. Conversely, if you are a believer in the philosophy expressed by root, weed, Orion, Scarlato, then you're going to say, I'm going to direct my hindfoot therapy at stabilization of that hindfoot, perhaps with orthotics, perhaps with an arthroresis, perhaps with a calcaneal osteotomy of some type, whatever you think is appropriate. And that first ray stability will occur secondary to stabilization of that hindfoot, because you're going to believe that if the hindfoot's unstable, we have an altered angle of pull of the peroneus longus, and then secondarily instability of that first ray. Regardless of which philosophy you accept, we all see these young patients that come to us with a bunion, frequently painful, a hallux valgus deformity, early hammer toe formation, and the question becomes whether intervention is required or not. We've seen some recent calls in the orthopedic community saying that one should not intervene or treat asymptomatic pronation deformities, and I suppose the philosophy is I guess we should just wait until they become symptomatic, allow these deformities to progress, because we do see young patients that clearly have evolving deformities, and this is not at all uncommon. And even at an early age, we can see rather progressive deformities present. The biomechanical examination, of course, is important, and when I look at the pediatric patient with a bunion, I'm going to get to the bunion, there's no question about it, but I want to see what contributing factors there are. We're going to look for suprapedal components, particularly if there is a unilateral presentation. I'm going to look for limb length discrepancies. I'm going to evaluate their hips and knees, look for scoliosis, look for deformities that could account for a unilateral presentation. We're certainly going to look for limitation of ankle joint dorsiflexion. We're going to evaluate the subtalar and mid-tarsal joints, both to see what type of frontal and transverse plane instability is present. We're going to look always for the presence of a metatarsus adductus, as I believe that this is one of the most common factors predisposing pediatric patients to early bunion formation. We're going to assess that patient as best we can for first-ray hypermobility, however one goes about assessing patients for that. And then we're going to do a non-weight-bearing and weight-bearing examination and look for the degree of pronation deformity. And sometimes we see things such as Kohler's disease. We may see patients such as this that manifest Ehlers-Danlos syndrome. We look for deformities that occur primarily in the transverse plane. And when I say transverse plane compensators, these are children that have forefoot deformities, such as you see here with an early bunion, increased intermetatarsal angle, hallux valgus deformity. And on the dorsal plantar view, we see a significant lateral subluxation of the mid-tarsal joint. We see marked abduction of the cuboid. And yet on the lateral x-ray, the foot is rather unimpressive in terms of expression of deformity in the sagittal plane. So these are patients that are theoretically functioning around a more vertical oblique axis of the mid-tarsal joint, a more verticalized subtalar joint axis, but they are patients that have a significant deformity, and yet on the lateral view, their x-rays are rather unimpressive. We always want to assess for metatarsus adductus, which can be presenting as just excessive adduction of the first ray, the medial 3 rays, so-called medial column adductus, or total adductus, where we have adduction of all 5 metatarsals. And I think with experience, you generally recognize these feet as soon as you walk in the door, because the people that have a medial column or total metadductus with a bunion generally have a very large bunion looking at you. They have a C shape to the medial column, an increased convexity to the lateral side of the foot. And these, from a practical standpoint, are very, very difficult to correct, because you know that you cannot align that first metatarsal with the first cuneiform without correcting the remaining bones, because the first metatarsal would literally crash into the second, so there's simply no room. If you try to align the great toe with the first metatarsal, you'll end up with the patient having A, either a hallux varus, or B, leaving the operating room with a stage 2, possibly even stage 3 residual deformity. So when I look very carefully for the presence of metatarsus adductus, and I'm very reluctant to engage these patients in immediate surgery. I sit with the parents, I sit with the patient, and I explain the deformity. There are those who look at the metatarsal cuneiform joint, and again, many great thinkers such as Paul Lapidus and James Canley looked at joints such as this and said there's clearly an obliquity to the metatarsal cuneiform joint, and some studies such as this have shown an increased medial column obliquity. I can tell you with certainty that the majority of these patients, when you go in surgically, have an elevated proximal articular set angle that's going to have to be dealt with, and a second metatarsal cuneiform joint, which is also elevated. So from a practical standpoint, these can be very difficult bunions to correct, and leaving them partially corrected results or contributes to, I should say, that 60% or greater reoccurrence rate. So a thorough evaluation of juvenile bunions are absolutely required in each individual case. You want to remember that many of these children have pronation deformities from the time they are walking. As a result, they have been functioning with abnormal subtalar joint or mid-tarsal joint function. They have been functioning with abnormal alignment of the and weight-bearing forces going through their joints all the time they've been walking. So they have significant joint adaptive changes. And this is an example of such a patient with a very high proximal articular set angle. I continue to marvel when I attend meetings and people with whom I have a respectful relationship, people that I respect tremendously, argue that, quote, there's no such entity as a high proximal articular set angle. And I sure think I've seen a lot of patients like this over the years where if you look at the alignment of their first metatarsal and the articular cartilage alignment, it almost looks as though you're looking at a femoral head. And what used to be the medial aspect of their distal first metatarsal is sort of like the greater trochanter, if you will. And because of this, either a proper subchondral wedge resection is going to have to be performed to realign that cartilage, or I suppose a cheater ache. And although I must admit that in the juvenile patient, I tend to prefer to realign the cartilage, although again, I have tremendous reluctance through experience in approaching any of these. This is probably the worst I ever saw. And here you can see a high intermetatarsal angle and what looks like a femur. It looks like a little teeny femur. And I would defy anyone looking at this photo, as poorly as I took it, to tell me that is not an elevated proximal articular set angle. In looking at surgery for the juvenile bunion deformity, I speak clearly to the patient and the parents, and I try not to cross-talk the child, because the child is sitting there and frequently they're listening to this conversation about cutting their bones and using pins and screws and nuts and bolts. And picture yourself being a juvenile patient listening to this conversation. So I try talking directly to the child first with regard to exactly how much pain they're actually having and how much this bunion does in fact bother them. I want to hear the child's viewpoint, not the parent's viewpoint. And yes, I talk to the parents, and yes, I'm respectful of that, but I don't want to cross-talk that child. I also, whether it's flat foot surgery or cavus foot surgery or bunion surgery or any reconstructive surgery in the pediatric patient, I want to get a feeling for patient expectations that their child is going to be, quote, normal. Because oftentimes we can improve the situation, we can improve the child's gait, we can improve the deformity. However, I don't want anyone to think we can do more than we actually can. I don't want the parents' expectations to be in excess of that of the surgeons. And frequently, perceived disappointment in surgical outcomes in treatment of our patients is due to just that, the fact that the patient or parents do not have the same view of the objectives of the surgery than does the surgeon. So we want to make sure we have a clear understanding with them as to what we can and what we cannot do and what's to be expected. We want to try to not do surgery if we can until growth of the foot has been completed. This is generally older in the male than the female patients, although generally we tend to see juvenile bunions more in the female patients than the male patients. General principles for doing bunion corrections in the juvenile or adolescent patient. Again, to me, the most important thing is to consider etiologic factors, because those are the factors that cause the deformity, and those are the factors that are going to be operative in increasing the risk for a recurrent deformity. Obviously, we want to do everything we can to avoid the physeal plates. There are some very few people who are respectful, however, who do variations of the Ellis procedure and will do partial physeal plate staplings or destructive procedures trying to limit the growth of the lateral physeal plate allow the medial physeal plate at the base of the first metatarsal to continue to grow and, quote, auto-correct, if you will, close quote, the deformity. Just from a practical standpoint, I personally think you're foolish operating on a physeal plate. There's a great deal of risk associated with this, and I don't know that there's anything lost in waiting until growth is complete. It's been suggested by many that we avoid or minimize soft tissue release in the juvenile patient. Some have suggested that osteotomies be performed extracapsular, although I'm not sure exactly how one would do this successfully, particularly given the fact that many juvenile deformities are associated with significant sesamoid displacement, significant lateral ligamentous and capsular contracture, and a high proximal articular set angle. So in general, I talk to the parents and the child. I express my understanding that the bunion is a bother to them. I will utilize orthotics or some pronation limiting therapy to minimize, if I can, the progression of the deformity until skeletal maturity. And I always plan for reducing the proximal articular set angle or accounting for that at the time of surgery. So this is an older case of mine where I've done an osteotomy both distally with digital corrections in a child with very advanced deformity. What about the use of osteotomies commonly performed, such as the chevron osteotomy? This has been looked at by some well-established authors, and while they recommend that one wait until skeletal maturity before correcting the bunions when possible, they do acknowledge that good results can be obtained with a distal V osteotomy. There are other less robust studies available looking at the use of the Austin type or chevron type osteotomy in juvenile patients with a good success, concluding that the procedure is safe and effective. Because there is a high proximal articular set angle in many of these patients, it is not uncommon to have to modify these osteotomies in order to not only reduce the intermetatarsal angle, but to reduce the proximal articular set angle, so that when going in, when thinking about our preoperative planning, we want to think about how we're going to modify the osteotomy that's intended in order to reduce the proximal articular set angle at the time of the initial surgery. Another study looking at the chevron osteotomy for pediatric bunion deformity, and the recommendation that one avoid sagittal plane malalignment as submetatarsal 2-3 transfer metatarsalgia not at all uncommon. The scarf bunionectomy has also been described in limited studies for the correction of bunion deformity in the juvenile patient. However, in this particular study, it was noted that there was a high reoccurrence rate of bunions following use of the scarf for the correction of juvenile bunions, and that it is difficult to correct the proximal articular set angle. If you think about the scarf procedure, in order to rotate the metatarsal to gain correction of the proximal articular set angle, you're going to have to rotate that proximal segment a great deal, and you're giving up bone-to-bone contact, increasing the risk for delayed or non-union. Another small study looking at successful use of the scarf procedure for juvenile bunion deformity. We have seen other procedures of a minimal incision nature recommended for use in a juvenile bunion deformity with success, looking at percutaneous osteotomy in the juvenile patient, utilizing the Reverden Isham osteotomy with no fixation and immediate weight-bearing post-op, utilizing toe spacers and bandaging for correction authors have reported excellent success under 18 degrees of angulation. Looking at the results, however, of percutaneous osteotomy, 20 of 33 hallux valgus deformities were in fact undercorrected. 9 patients had complications, and there was, however, overall a high rate of patient satisfaction. When we have metatarsus adductus present, again, when I look at an x-ray such as this, I go in thinking, yes, I have to reduce the intermetatarsal angle, I have to reduce the hallux valgus, but there's a likelihood that there's going to be a high proximal articular set angle. I mentioned earlier that some have advocated the Ellis procedure, that is to say, stabilization of the lateral physeal plate in order to allow continued growth of the medial physeal plate. But really, if we look at the results and the correction obtained, it's really minimal, and in my own personal opinion, I think the risk is probably greater than the reward for this type of procedure. But in fairness, there are those who have reported decent results with significant improvement in patients with epiphysiodesis. So we want to evaluate each one individually. I think this is more an example of the type of correction that I do when I have to do them. This was a patient of mine who had a high IM angle, had a high proximal articular set angle, and required a classic double osteotomy of the Logroscino type in order to reduce the intermetatarsal angle, reduce the proximal articular set angle. Looking at double osteotomies such as this for the correction of juvenile bunions, Johnson reported 90% good to excellent results. And again, I think that's understandable given the fact that we must reduce not only the intermetatarsal angle, but the proximal articular set angle. This particular study looked, however, at single proximal versus single distal versus double osteotomy. They looked at an average age of 14 years and found that single distal osteotomy gave the most consistent outcome, whereas single proximal metatarsal osteotomy was associated with the highest reoccurrence rate. With reference to the Lapidus procedure, we have seen that advocated in the juvenile patient, but again, the open physeal plate, I think, makes this difficult. With metatarsus adductus in particular, again, we have to deal with the fact that we have limited ability to reduce the intermetatarsal angle, and we typically have a high proximal articular set angle. Looking at metatarsus adductus and its relationship to hallux valgus, we realize that metatarsus adductus tends to cause our underestimation of the effects of the intermetatarsal angle. We were taught a formula at one time, if you recall, and I'm sure the older listeners do recall this, when we were told that we should accept an average metatarsus adductus angle of 14 to 16 degrees, and that we should measure the first intermetatarsal angle and add to that every degree over 14 to 16 degrees. So, for example, let us say we had 26 degrees of metaductus and 10 degrees of intermetatarsal angle, that we should treat that patient as though they had a 20-degree intermetatarsal angle. And while this probably is correct in theory and practice, the point is, when all is said and done, we only have so much room to move that first metatarsal regardless of what we measure. With metatarsus adductus, we also want to remember that many patients may have hidden metatarsus adductus because they have a pronatory compensation for the deformity. In my experience, bunions with metatarsus adductus have a low intermetatarsal angle. They have a high hallux valgus angle because their toe is being dislocated from a very early age because of their pronation instability and the presence of their deformity with metaductus early on. And they almost always have a high proximal articular set angle. If one sets about doing bunion corrections in the juvenile patient, as in the adult patient, with a metatarsus adductus which is uncorrected, there is in fact a high reoccurrence rate. So one has to consider either reduction of the entire deformity or doing a stabilizing surgery such as a Lapidus procedure or an open-up wedge osteotomy at the first cuneiform joint in order to obtain such stabilization. There are authors who have described, again, modifications of the Lapidus procedure for use in the juvenile bunion deformity. So in summary, I try to avoid early surgery in the juvenile or adolescent patient with hallux valgus deformity. When confronted with this, we want to realize that frequently this is representative of a more global problem. We want to consider etiologic factors, and I think the most common ones, other than hereditary, are metatarsus adductus deformity, the existence of a concurrent significant pronation deformity, or the presence of ligamentous laxity. I discussed the findings and options with the parents and child, and if possible, I do everything I can to encourage them to postpone surgery until growth is complete in order to reduce the likelihood of a recurrent deformity. Anytime I'm dealing with a juvenile bunion deformity, I plan for reduction of a high proximal articular set angle. One wants to avoid the physeal plates. And if one looks at the literature, the two most predictable procedures are either isolated distal metaphyseal osteotomy, which frequently has to be modified to reduce the pasa, or a double osteotomy of the first metatarsal and both proximally and distally. Hopefully this will give you some thoughts on treatment of juvenile bunion deformity. Thank you for joining us.